cardiovascular study. Now, if you look at the varying cutoffs for having the metabolic syndrome based on a single criteria, I think what's useful is diastolic triglycerides. It doesn't show up. This is fasting glucose. This is systolic blood pressure. This is HDL. And this is waist circumference. And what's interesting is rarely do you see a cutoff that so clearly defines affected or separates affected from unaffected as you do with the waist circumference. So if you exceed the criteria 88 centimeters, almost all these patients had the metabolic syndrome. Similarly, if you want to look at BMI, no one with a BMI less than 27 had the metabolic syndrome. Now again, I think that would be somewhat different. We know that you see higher rates of metabolic syndromes at lower cutoffs of waist circumference and BMI in an Asian population. This was predominantly a Caucasian and an African American population. But still, what it suggests to me is that centripetal obesity / obesity is the metabolic risk factor. And so when I go and go further and show you studies, I'm not going to show you every lipid level, every CRP level, everything else. I'm going to focus primarily on obesity as the surrogate marker for the cardiovascular risk factors in this population. Now, one thing that we see is that cardiovascular risk factors cluster in these families. So we do believe that these families are enriched for both risk factors and, at least in the males, for events. So one of the things that we noted early on, and we started studying, so we identified a woman with PCOS, and then we brought in all her sisters and began studying them. And this slide right there is just only sisters. So these are women that were identified because they had a proband sister with PCOS. And we went in and phenotyped and then found that there were different phenotypes within the family, much like the varying criteria. There were some for PCOS. Some women had the full phenotype of hyperandrogenism, irregular menses, polycystic ovaries. Others had regular menses, normal fertility, lower weight, and just had elevated circulating androgens. And we found that within these families, that the hyperandrogen was a marker that correlated with metabolic dysfunction. So I can show you this data, and I won't go into too much, but for insulin resistance and for dyslipidemia and other cardiovascular risk factors cluster with high androgen levels in the females. Similarly, when we went in and we took a look at the mothers, it's a little bit more difficult with mothers because many of them are menopausal, so we did something that I'm going to criticize very shortly here. And we tried to assign a PCOS phenotype to the mothers on the basis, one, of their history of menses during their reproductive life, and two, on their current androgen levels. And what we found is that the mothers that were irregular, so suspected PCOS, had much higher evidence of elevated testosterone levels, of elevated glucose levels, of insulin resistance, and they also had higher LDL-C levels. When you look at the brothers, and we've studied both brothers and fathers in this ongoing study, we also find the brothers have increased prevalence of hypercholesterolemia, elevated LDL-C, triglycerides, compared to control populations. And also higher prevalence of metabolic syndrome, both in the brothers and the fathers of these women that we've identified. We've gone ahead and we've collected data on events in the fathers. And this is primarily a young group. The mean age of the fathers in this study is about 54. And we find that in the fathers, there's about a twofold risk increase, both of heart attacks, and I won't show you the data here, but also of strokes. So these are events that have already taken place by a mean age of 54. And about twice our reference population, the NHANES, which is a systematic survey of the U.S. population. And interestingly enough, in the mothers, we do not find any increased event rates, either myocardial infarction or strokes. And I think that's consistent with, I think also what we're seeing with the daughters. And I think one of the big difficulty with having a lot of risk factors is the relative paucity of events that have been shown in studies. There is, as we've gone ahead and developed imaging technologies that can better detect subclinical atherosclerosis, most of the studies supported an increased prevalence of subclinical atherosclerosis in women of PCOS compared to control populations. One of the things, though, is you have to take a look at the absolute risk. So this is a study that I'm going to show you some data later on. It was based at the University of Pittsburgh. It's an epidemiologic study, came from the Department of Epidemiology. Lewis Kuller was the PI on this. And what they did is they took a look at cases and controls of women with PCOS, and they actually re-examined them at three 5-year intervals. And so when these women initially came into the study, they were in the mid-range of 35 to 40, and they eventually followed them through the menopause. So both cases with PCOS and controls. One of the things they did along the way is they took a look via ultrasound at intimal medial thickness. And they did find an increased prevalence in women with PCOS, especially as they went through the menopausal transition. But if you look at the absolute risk, so of an abnormal plaque index, is 7.2%. So you can also say that 11 out of 12 women were completely normal that had this history of PCOS. Nonetheless, the incidence was markedly increased in women with PCOS compared to controls. If you take a look at some of the epidemiologic studies, and part of what I'm going to show you a bunch of epidemiologic studies, and what people are trying to do is there's been no, other than this University of Pittsburgh study I just showed you, in the U.S. there's been no prospective epidemiologic study of women with PCOS that has followed them through the menopausal transition. Instead, researchers go into existing databases and try and post hoc make a diagnosis of PCOS, either based on their report of their menses or based on their testosterone levels if they're able to measure that, and sometimes based on their own self-report of whether they had PCOS or not. And these studies fairly consistently have shown an increased incidence of coronary artery calcification, as in this ECAC study. And interestingly enough, the prevalence, and this was a pre-event population, matched that as the males in the study. But you can find other study, and again, to provide a balanced data, this was just a study from the Dallas Heart Study that a researcher pulled out the PCOS women, and in this study they had done both coronary artery calcification, and they also looked at aortic plaque formation by MRI, and they found no difference between cases and controls in this study. So now the big issue, what about mortality events in women with PCOS? I'm sure you all remember Cuba Gooding and Jerry Maguire. You know, he's always saying, show me the money. So I think that's the same thing when people start talking about cardiovascular risk. It's like, show me the events. Where is the data that says that these women have increased events? This is one of the papers I came across. It always amazes me how we can know such obscure things. Like someone did a study and found that Catholic nuns that are radiologic technologists are less likely to die than radiologic technologists who are not Catholic nuns. Okay? So we have this important piece of information that we can counsel our Catholic nun patients who are also radiologic technologists. What are we supposed to tell our women with PCOS? Well, this is actually the only study that I'm aware of that takes women with PCOS and follows them through to their death, and went in and pulled the death certificates and the medical health record and tried to figure out what did these women die of. Now, part of it is PCOS, it's a diagnosis that's been aided by ultrasound, and in the past, prior to ultrasound, this diagnosis was made during a laparotomy, certainly up to 1970, where a woman underwent a wedge resection, and you all know the classic Stein-Leventhal syndrome, a syndrome that was both diagnosed and treatment was proposed for it. So they would take the women, open them up, and do a major wedge resection. And that's what happened in these women. And they went back to the pathology and confirmed that indeed that these women had polycystic ovaries on the histologic examination of the wedge resected ovary. Some people argue that these women were substantially cured by the surgery, because there's been good data to suggest that many of these women develop normal menses, normal fecundity afterwards as a result of the wedge resection. And so this really represents a treatment-biased population. So they took a look at the death rates in this group of women, so 800 women. And what they found is that there was really no increased cardiovascular, no circulatory deaths. So there were not increased myocardial infarctions. There were not increased strokes. Now, certainly you can argue, and from the previous presentation, I'm always humbled when a cardiovascular diabetes person presents, and then we poor PCOS people have to come up with our studies. We're lucky to have a study with 100 people in it, and here you have these epidemiologic studies with thousands.